suicide prevention in children and adolescents. If you are a physician or can claim AMA, CME credits for continuing education, there is an opportunity to gain free credit for this webinar. Additional information was provided in the reminder email sent from WebEx at 10 a.m. this morning. If you are eligible to receive these credits, please make sure to complete the online survey that will pop up when we end the webinar. If you experience any difficulties with this survey, please send an email to Kim Sloof at this email address on the slide. None of the presenters have anything to disclose. Hello, my name is Flaura Winston. I'm the Senior Advisor to the Violence Prevention Initiative and founder and scientific director of the Center for Injury Research and Prevention. This webinar is being hosted by the Violence Prevention Initiative at the Children's Hospital of Philadelphia. For those of you who aren't aware, this is a CHOP-wide effort to interrupt the cycle of violence. VPI builds on years of hospital and community partnership and research to provide the right care to the right children at the right time. We have lots of resources online, and I encourage you to go there and to come and be involved in this important initiative that spans the entire hospital and network. Our goal today is to address the second leading cause of death for young people ages 10 to 14, which is suicide. A new CDC report has updated suicide rates for children ages 10 to 14, and I have to say it's disturbing. For the first time ever in this age group, deaths by suicide have surpassed those due to car crashes. While car crash fatalities for tweens have been cut in half since 1999, suicide deaths have doubled. While boys are still more likely than girls to commit suicide, 275 boys to 150 girls in 2014, the rates for girls committing suicide in this age group have tripled, across the ages as well. Complete suicides are the tip of the iceberg. Suicide attempts among 10 to 14-year-olds rose 135% between 2001 and 2014. Our goal today is to discuss how CHOP as an institution is addressing this issue and the critical role that frontline staff have in detecting warning signs of suicidality, assessing suicide risk, and actively getting at-risk youth to the appropriate treatment. I have been honored to be a primary care provider at CHOP for over 20 years. I know that many of us feel challenged to fit everything into an appointment slot, but we all know that some of our most gratifying moments were those extra few moments that we spent for a child in need. These are the ones we will never forget. Like the 9-year-old girl who I had as a patient for years, and life was turned around for the good because of a concern around depression that was triggered by a suicide screen that I had conducted and appropriately referred her. Or the teen with a series of ED and sick visits prompted by probing that led to detection and urgent referral for depression and suicidal ideation. The good news is that we have lots of resources available to people today to make this type of work on the front line easier. Before I introduce our speakers, I'd like to address a few housekeeping items. First, if you're having technical difficulties, please reread your confirmation emails. The latest one was sent at 10 a.m. this morning. In the emails, you will find links to join the meeting and to download WebEx Event Manager for the first time, if you're a first-time user. You should hear the audio through your computer speakers. There is not a call-in number, unfortunately, for the audio. From this point forward, we will not be able to help you with technical issues. If you have questions for the presenters as we go along, please feel free to type them into the Q&A text box in the bottom of your screen and direct them to our host, Lindsay Mitros. She and I will collect and prioritize the questions by looking for common threads. At the conclusion of today's presentation, we will address as many questions as possible. If there are additional questions after the webinar, please feel free to contact our speakers. Because of the large group, it is not possible to open up the line for audio-verbal questions. Also, other participants will not be able to view the questions or comments you submit. From previous webinar feedback, we've learned this is very distracting for the participants, so please be assured that we are taking all of your questions into account and will get to as many of them as possible. The agenda for the next hour is about 40 minutes of lecture on the following. First, to discuss the current state of depression and suicide in children and adolescents. Second, to explore screening options available to providers at CHOP. And three, to discuss what to do with a positive screen, including barriers to follow-up and how to handle them. Lastly, this webinar is being recorded and will be posted at www.chop.edu/violence within the next week. We're so excited that we have more than 80 people registered for today's webinar, seeking to CHOP's clinician interest and concern in addressing depression and suicide prevention among today's youth. Among participants, we see people from many disciplines across CHOP: medicine, nursing, social work, health administration, education, health educators. If we're not describing your discipline or role at CHOP, please text us in the Q&A and let us know. Now, it is my honor and pleasure to introduce our speakers, my dear colleagues. First, I'd like to introduce Dr. Anik Jhonsa, who is a psychiatrist and is served as the Medical Director of Emergency Psychiatric Services here at CHOP. He is also the Assistant Training Director of the Child and Adolescent Psychiatry Fellowship Program and a Clinical Associate within the Department of Psychiatry in the Perelman School of Medicine at the University of Pennsylvania. Our other speaker is Dr. Jeremy Esposito, who is an attending physician in the Emergency Department here at CHOP and a fellow of CHOP's Violence Prevention Initiative, a group of dedicated experts who are here to help support the violence prevention initiatives across the hospital. He is also an assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Dr. Esposito's research focus involves increasing awareness and screening of mental health concerns during patient encounters, improving care for behavioral health patients, improving follow-up through better communication once these patients leave the emergency department, and advocating for additional resources. I will now turn the mic over to Dr. Jhonsa.
Hi everyone, thanks for joining us today. We're going to start by talking a little about the current state of depression and suicide in youth in America at this time. There's been, unfortunately, a drastic increase in suicide rates for all age groups. The 2013 Youth Risk Behavior Survey outlined that 24% increase in suicide. And as you can see by the graph here, the rates between boys and girls, both in terms of feeling depressed and planned suicide attempts, as well as attempted suicide, and also those requiring medical attention. Important to note is that not all people who attempt suicide or have a planned suicide attempt seek medical attention, and nationwide only about 40% of those that actually present to an emergency room with any sort of self-interest behavior or parasuicidal behavior actually sees a mental health screening of any sort. So this is a problem nationwide. I'm glad to say that our numbers at CHOP in our emergency room through some of the initiatives we're going to discuss here today are significantly better than those, but this is a problem that people are facing around the country, and we're all looking to find good solutions on ways to move forward. In 2012, the CDC listed out the 10 leading causes of death by age group, and I think everyone kind of knows the number one cause of death amongst most of these sort of unintentional injuries, a motor vehicle accident, unintentional injuries of any sort. As you can see in the green boxes, suicide from ages 10 to 14 was the third leading cause behind women neoplasms, and for ages 16 to 34, has actually increased steadily between the second leading cause of death. Going forward, looking at the 2014 data, now suicide is the second leading cause of death for all patients between the age of 10 and 34, and it's becoming a major issue. So when you add up all of the things that we think as primary care doctors people spend a lot of time on, cancer, asthma, cystic fibrosis, heart disease, kidney disease, flu, stroke, diabetes, liver disease, just to name a few. At this point, if you have a patient who's aged 15 to 24, the number one cause of accident accidental trauma. The number 2 cause of suicide. The number 3 is homicide. You take all of the top killers, numbers 4 through 24, and you add them all together. And unfortunately, we're losing more kids to suicide in this age group than all of those causes combined. This is some prevalence data from 2015 of adolescents that had a major depressive episode, and a few things I wanted to point out. As you can see, one prevalence is 12.5, so 1 in 8 patients that you see are who are adolescents from age 12 to 17 are likely to have a single depressive episode at some point over a year. The number is significantly higher for female to male. The ratio between male and female post-puberty is somewhere between, this data kind of has it about between 3 and 4 to 1, but most studies kind of peg it around 2 to 3 to 1. But as you see, the rate rise as people are getting older, and then also the rates of certain ethnicities are, all ethnicities are higher than we would like to be. So for depression, through childhood, pre-puberty, there's pretty consistently, most studies have shown a 1-to-1 male-to-female ratio. However, that ratio does increase students or females having higher prevalence of depression post-puberty, and that risk increases by a factor of 2 to 4, particularly in females, for all youth post-puberty. The important point that I just wanted to speak in here is that when you're talking to kids and when you're talking to any adolescent or youth or in fact any patient, people across all age groups are better reporters of internalizing symptoms. So we're talking mood, anxiety, any sort of depressive symptoms. The patient themselves is going to be a significantly better judge of how they are doing with those symptoms compared to any sort of external person, such as a caregiver. Disorders that we call externalizing, like ADHD, parents and caregivers tend to be better judges of how people are responding to treatment or how they're doing. The internalizing disorders, in particular mood and anxiety that we're talking about today, the patient is going to be your best reporter of how they're doing with their symptoms. And often parents will tell us that they had no idea their child was feeling a certain way, if the child was suicidal or had thoughts of harming themselves, then they're really forced to find out and after it has uncovered it. I'm going to really briefly go over some of our criteria for major depressive disorder. These are all very easily Googleable or you can find them online in many places, but I wanted to touch on some important things. So to have a diagnosed major depressive disorder or episode, you need to have 5 or more of 9 symptoms over a 2-week period, and that would represent a change in baseline. And at least one of the symptoms has to be mood or loss of interest in pleasure, which is also referred to as anhedonia, and they're not attributable to other medical conditions. And just briefly go over the 9 criteria. We're talking depressed mood. The number 1 symptom of depression in adolescents and youth, and particularly younger children, is actually irritability more than depressed mood. You're very rarely going to have an 8-year-old come to you and say, I'm feeling very sad and depressed and having lots of neurovegetative symptoms. They're going to more likely tell you that you're going to see a lot of irritability, a lot of noise, things of that nature. And there might be some signs that it's in younger children that may prompt you to screening for depression. The other symptom, suicidal thoughts, and this is not sort of just thoughts of, there's thoughts of wishing he's not alive anymore, wishing that the people are here, wishing everything would end, so those kinds of suicidal thoughts happen, as well as active thoughts of intent and plan for ourselves. Lack of interest in previously enjoyable activities, we also refer to as anhedonia. They're not engaged in their activities, they're not engaged in wanting to hang out with friends. So the video game that they used to love playing, they just don't want to do anymore, they'd rather sit and buy it. Feelings of guilt or hopelessness about their future, this could be feeling about an event that's happened in the past, or feeling like their situation in life is not going to get any better, whether it's bullying, whether it's a social situation, whether it's something with your friends. a decrease in energy nearly every day for the 2-week period that we're talking about, not wanting to get out of bed, not wanting to sort of get engaged in things that they would normally be excited to do. Similarly, a decrease in concentration, we're talking about a change from baseline. So it's always good, particularly in kids with ADHD who already have baseline concentration issues. You want to look for a change from where they were previously during this sort of suspected depressive episode. Change in appetite could be hyper or hypophagia, so we're talking about a 5% change in weight over a 1-month period, either an increase or a decrease. You can also be looking for failure to make expected weight gain for children. A lot of times kids might plateau with their weight gain, even though they should be, because they're getting taller, or they should be growing. So you want to also look for people sort of falling off their growth curve, which could be a good sign that maybe there's something else going on. Psychomotor agitation or retardation is essentially a lot of restlessness or sort of excessive, still not really responding to people in sort of a way that expects that someone's normal, not really interactive with the world around them. Again, this is one of those symptoms that actually external providers and parents and caregivers and doctors can be better judges of than actually patients themselves, which is a little different than sort of the internal feelings of depressed mood or agitation. And then change in sleep. Nearly every night, this will either increase or decrease in sleep. You know, sort of phase insomnia when people are having trouble falling asleep or frequent awakenings in night and trying to get a sense of a major change. And people say, oh, I'm sleeping less during school days because school just started. Now, when a person sort of is a similar person says how much are they sleeping on the weekend when they don't have school, and sort of trying to share through some of those other factors that could be affecting their sleep. So one of the major changes from DSM-4 to DSM-5 was they essentially removed the sort of bereavement exclusion in major depressive disorder. So responses to significant loss pay was done more with depressive episode, and certainly there is normal bereavement and normal loss and someone going through an adjustment period from either a loss of a loved one or even just some sort of major change, potential divorce or anything of that nature. However, if the patient is still having the symptoms that meet criteria for major depressive disorder and is having an impairment in functioning, you really want to consider that there is also a major depressive episode going on, and it's not just sort of normal loss or adjustment. This does require a clinical judgment and really the presence of screening and discussion when this is sort of when this is the situation you're dealing with. Some risk factors for suicide, family history, the first-degree relatives in particular, who've had a history of completed suicide or suicide attempt, active substance use or intoxication, access to firearms is a major one. About 40% of the completed suicides in that 15 to 24 age range are patients who completed suicide with a firearm. Gender, like we talked about earlier, posterior can be greater than male in terms of risk factor for attempting suicide. However, males are about 4 times more likely to actually successfully complete a suicide attempt than females. A lot of this tends to go back to the chosen method. Males are more likely to access firearms and things of that nature and push a suicide attempt to completion. They're also more likely to use things such as sort of hanging and resuscitation. And also, ongoing serious or chronic medical illness is also a big risk factor for patients attempting suicide. And some of the numbers in the type 1 diabetes population, kids dealing with sickle cell disease, are certainly higher than the baseline of kids without these illnesses. And obviously, the apnea suicide oncology patients doing more is also unfortunately higher than baseline. Some other risk factors for suicide, any sort of history of trauma or abuse, prolonged periods of stress, feeling isolated from those around you. Age as they get closer, higher in their adolescence, and then any sort of recent tragedy or loss. Sleep deprivation is probably one of those really underdiagnosed or underlooked at risk factors for suicide. Well aware the American Psychiatric is recommended, has this had the high school back, and there's a large concern in the mental health community that a whole group of our high schoolers in America that are mostly chronically sleep deprived, and due to that really are struggling with their ability to cope and deal with when other sort of external factors or other external issues come into play. So we're going to talk about some current issues, and I'm sure you're all familiar with the black box warning. So for those who aren't, the FDA introduced the black box warning for SSRI use in adolescents back in 2004. And since that black box warning came into play, SSRI prescribing has reduced and we've had statistically large reductions among all ages, but primarily among adolescents and young adults, down between 25 and 30%. So I wanted to give a moment to provide some education on what the black box warning is, because I think a lot of people just sort of hear that it exists, and they get very sort of scared about the idea of possibly prescribing an SSRI. So the black box warning came about from a meta-analysis that looked at 372 randomized trials of patients that were given SSRIs. There was about over 100,000 patients. None of the individual studies actually found this. I think that's obviously one of the great things in meta-analysis is you can pull a lot of data together and kind of get some group data. And what they found is that there was about an increase from at baseline, adolescents had about a 2% chance of having suicidal thoughts, and when they were on SSRI, there was about a 4% chance based on this meta-analysis. That was found to be statistically significant. However, in the study, I think it's very important to note, there was no increase in suicide attempts, and there were no completed suicides in the study over the 100,000 patients. So while patients were more likely to have thoughts, and thoughts could certainly be a precursor and a risk factor for future attempts, there were actually no increase in attempts, and there were no actual suicides. There's nothing out there from the data that actually shows that your patients are more likely to actively harm themselves should they be on an SSRI. There's been wide-ranging fallout from this, and I think this is, to go back to those thesis slides we were looking at the beginning, I do firmly believe that this is a big contributing factor to what we're seeing. So there was a reported increase of 22% in suicide attempts among adolescents and 34% among young adults following the black box warning. A lot of that had to do with people being pulled out of care, being titrated off or taken off their SSRIs, or being care to take because they didn't understand that they start having a real passive SI or maybe some mild SI, and then they were pulled off of their antidepressant, which could have been a protective factor, and then there was actually suicide attempts. The other major factor is that since the black box warning has come out, there's been a major reduction in screening in primary care sites following the black box warning, and basically down across the board, but mostly among children and adults. From the primary care providers I've talked to, they've often felt like, well, they lost their tool to address it, so now they didn't feel like equipped to start asking questions that they didn't know what to do if they got a positive answer. We're going to look back around to some ideas and options for treatment and, what you should do in this situation by the end of this webinar. But I really want to point out that this data really shows that there was not a decrease in prevalence, but just a decrease in primary care providers diagnosing depression on their own. And you look at the numbers, 37 and 44%, pretty significant. Is screening dangerous? It's a pretty common misconception of this that asking about suicide should actually lead to someone trying to attempt or thinking more about suicide. They've actually done numerous studies on this, which show that asking about suicide does not lead to any increase in action. And actually, multiple studies have shown that asking about suicide can actually reduce the incidence and prevalence of suicidal thoughts in patients. So it's as far as I'm concerned, always important to that. And I'm going to be passing over to Jeremy, who's going to talk to you guys about asking about suicide.
Thank you, Anik. So in 2016 in February, the U.S. Preventive Services Task Force updated the recommendations for depression suicide screening. They recommended that all adolescents aged 12 to 18 years receive screening for major depressive disorder when there's adequate system in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up. According to the AAP's updated clinical report from July of this year, screening for depression is recommended patients 11 to 21 years of age. Suicide screening is routinely recommended. You saw the statistics earlier showing that suicide was the second leading cause of death in our patient population, and therefore we really must treat suicidality as a medical emergency. As providers, we're always trying to think of illnesses and injuries that can harm or kill our patients. This doesn't only hold true in the emergency department. We really need to realize how severe this health crisis is, and that's our ultimate goal for vets. Ignoring the problem doesn't make it go away. We've seen that it's only gotten worse. More importantly, 75% of patients that complete suicide have seen a medical provider within a year of completing suicide, and actually 40% make contact with their primary care provider within a month of suicide. Before I talk about screening options available in the primary care setting, I wanted to talk a little bit about the screening process that happens in the emergency department at SHOP. A behavioral health screen was developed and implemented in 2009 by my colleague Joel Pine, as well as guidelines and his team currently at Drexel University. Studies actually at SHOP and other ED sites suggest that screening with this tool is both feasible and valid. In the ER at SHOP, we see over 95,000 patients a year. We've been able to implement this electronic screen to patients greater than or equal to 14 years of age, and it's actually given by our nurses, ideally at the beginning of the ED visit, but it actually can be given at any time during the visit. It consists of 50 questions and takes about 10 minutes to complete. The screens for depression, suicidality, trauma such as PTSD, substance use, and gun safety. Although we're always trying to improve how many screens we do per month, we do about 300 to 400 screens per month, which is pretty impressive in our busy ER. This is an example of the results that show up once a patient completes the behavioral health screen. Providers can then review each question in subsequent stages. I should note that this behavioral health screen done in the emergency department can be found in the media tab in Epic, and PCPs or other clinicians within the SHOP network can access it after the ED visit. This graph summarizes the percentages of behavioral health screens done each month with severe depression or current suicide in 2015. These are the patients we really focus our attention on in the emergency room. As you can see, about 30% of screens done each month are positive for severe depression, which is about 100 patients out of 300 patients that complete the screen. About 8% each month are positive for current suicidality. I know when I actually reviewed these statistics, I was very shocked, and really the screen should do a lot more for this. And also to note that many of these patients that present with these positive findings present with a non-psychiatric chief complaint. I want to talk briefly about a QI project that I started in 2014 to give an example of the screening workflow, the challenges, and some of the solutions that we came up with. We definitely face obstacles every day, but we are also constantly trying to improve the process. Our hope is that you can all leave this webinar inspired to think about how your current process works, and even how you can start. Steps highlighted with an asterisk are areas we focus on. Instead of printing the results of the behavioral health screen, where it was often lost or missed, this now shows up in the electronic medical record. A little bit more on the QI process, which began in 2014. We really wanted to focus on the patients that were discharged from the emergency department with a non-psychiatric chief complaint with severe depression or suicide risk on the EHS. Those that get admitted to the hospital or transferred to inpatient psychiatric care are leaving the ED with a plan to get continued care. So it's really these discharge patients that we wanted to look at. And despite the screen being around for years, there were some mixed emotions on important lack of knowledge about mental health illness from our own faculty and providers. There was uncertainty about the results and what's happening to the patients who screened positive. It really did require a lot of chart review to realize that we were doing a pretty poor job in documenting and communicating to our primary care providers. And additionally, we were seeing several missed opportunities and multiple return visits to the ED. So some of the interventions that we put in place were creating electronic alert and smart text that would go into our ED notes. We met with a lot of top primary care providers and got some feedback along the way. We had regular division meetings within our emergency department and also made some updates to our clinical pathway, which can be found through Google if you Google top clinical pathways. So this is the alert that shows up in the emergency department after a patient takes a behavioral health screen. So all residents, nurse practitioners, fellows, attending see this alert that shows up until they can click the bottom of the alert and actually view the results of the behavioral health screen. And then it really kind of goes through a process since we have so many people rotating through the emergency department as trainees, tell them what to do with positive screen. As you can see, with severe depression or current suicide risk, we really want the providers to clarify that talk to them alone. And if they're still concerned, talk to our social worker who's very involved in our emergency department. If the patients are deemed safe for discharge, but they're not currently suicidal or at risk for suicide at this moment, we deem them safe to be discharged. We've given them resources for therapists and mental health care and outpatient settings to pursue. We really want to add another layer of follow-up by communicating to the top primary care providers and then non-top primary care providers. So if patients are followed within the CHOP network, we send an in-basket message to the pool of the practice and also CC the primary care provider. For non-CHOP PCPs, we attempt to call the office and we document this in our notes. If you look at the bottom of this slide, you'll see some examples of databases that we incorporate into our ED note that really give a general approach to documenting what we did in the ED, maintaining confidentiality, and helping ED providers document quickly what they did without having to retest a lot. So this QI project went from January 2015 to March 2016, and as you can see, there were almost 5,000 behavioral health screens completed during that time frame, and consistent with the previous statistics is about a third the screen caused for severe depression, and about 8% or so had current suicidality. So I reviewed 783 charts manually, and 75% of those patients presented with a non-psychiatric chief complaint. 86% were discharged from the ED, so a lot of them are being safe to go home. As you can see, the most common non-psychiatric chief complaints included these non-specific symptoms that we see every day, including abdominal pain, chest pain, and headache. So following along how we did during this process, documentation an attempt to contact the primary care provider increased from about 3% prior to the alert and reached 53% during the final 3 months. We're always trying to improve this process. Nothing's perfect, but it was a step in the right direction. We improved our documentation within of the screen results within our note. Even more importantly, when we did communicate these findings to the primary care providers, 76% of them within our primary care network acknowledged ED communication of the behavioral health screen follow-up since October 2015. So now moving on to training in primary care, it's important to realize that the care for our mental health patients really can be improved when we increase our knowledge, skills, and comfort. The more we do something, the more we think about it, eventually it's going to become a little bit more easier to incorporate it into our practice. Sometimes this requires a culture change. Not going to be easy at first. Definitely was not easy in the emergency room, but really when you push through it, it's really a look at what's going on. Along the way, we definitely found that it gets better over time. So I encourage all of you to map out your think about what is the best way to screen at your practice. It may not be the same for all places. Think about what are the available resources. Some offices have social workers right there on site. I know that within SHOP, if you didn't know already, you could, during the daytime hours, call consult social work over the phone. On off hours, you could engage the on-call social worker to help with referrals, questions. But really sitting down to think about what you have. Then also think about, do you need any additional resources and training? And another thing is how will colleagues help each other out? One primary care provider that I talked to within our network said that really when you find a patient that is suicidal, it really becomes an intensive process as you assess the safety risk and management. So it really should be treated like a code in a sense. You wouldn't let a sick asthmatic or a septic kid be unattended in your office. So really helping each other out by maybe seeing the next patient for them so that they can really take the time to assess the suicidal patient and get them to the appropriate place. And then lastly, how would you follow up with these patients? So you call them the next day or the next week? How would you keep track of them? So really thinking about these processes ahead of time are important considerations. As far as screening, what tool, what method that you're going to use for screening, you really want to think about some of these factors. So is the screen acceptable? Which really is what families want. They want it to be something that's not judgmental, with no stigma attached to it. They want it to make sure that privacy is kept as thorough and sensitive. That screen should be efficient, which is really what we want. We want it to be integrated into clinical care. We want it to be clear and concise. Have those results presented to us simply, and then the mechanism for referrals if needed. Then effective screens, making sure that the screen has useful questions, important domains, and reliable, so valid screens. And then as far as screening options, interviewing the patient alone or using validated screening tools are a couple options for you. We'll talk about this a little bit more. So screening can either be universal, which are given to all patients regardless of risk factors or symptomatic presentation. So this is what we try to do in the emergency department with the behavioral health screening. And then also screens can be targeted, so only given to those with particular symptoms or risk factors. So maybe if you're seeing a lot of abdominal pain, chest pain, headache, or if you have any of the signs or symptoms that Anik went over earlier, you may want to focus your screens on them. But I do encourage universal screening whenever possible. So as far as interviewing the patient, really studies have shown that relying on a chief complaint and then standard interview done by the physicians under-identifies depression. It's really important to try to talk to the patient alone. Making it a normal practice because these patients alone and talking to them alone really makes it a little bit easier along the way. So sometimes I'll say, I talk to everyone alone at your age, so I take a couple minutes, and I'll bring you to where you wait, and I'll take you shortly. You really make it a normal practice, and it really, I remember the last time that a parent refused to step out of the room. And then when you do get the patient alone, make sure you sit down. You don't want to be standing over them. You really want to have a personal conversation with them. I also might say something like, just like I had to check out your body, I need to check out your mind as well. This is a chance for us to talk about anything. Whatever we talk about stays between us. This includes drugs, rock and roll. However, what we talk about is confidential. Your safety does come first. I need to tell someone if anyone is hurting you, you want to hurt yourself, or if you want to hurt anyone else. And then I would make sure that they have an opportunity to ask me any questions before I begin. Once you're screening through an interview, many people have heard of the HED assessment. Some people at SHOP call it the SHAD. I usually encourage starting out with something like questions. So don't start out with asking up to type right away. Sometimes I'll ask about what you like best about yourself, or what you want to do when you're in high school, what do you want to do when you grow up. When you do the suicide screening session, asking simply, have you ever thought about killing yourself or wishing that you were dead? And then regardless of the answer, the next question should be, have you ever done anything on purpose to hurt or kill yourself? If yes, any of these questions, ask about suicidal plans. If you were to kill yourself, how would you do it? So there is no data to indicate, again, like Anik said, that asking about suicide precipitates behavior, even in high-risk patients. There's also some resources on the AAP website, in case anyone wants to reference that. Some of them, most of them are for free, but there are a couple of toolkits that can be purchased. And there's also additional resources, which we'll be happy to talk about if you have any questions. There's smarter screening tools that are out there and validated. These are a couple that I've listed here. So these are some that some actual primary care sites are using. And Columbia Suicide Severity Rating Scale, something that possibly could be in the works within the Trust Primary Care Network, but stay tuned for that. This is an example of PHQ-9. So depending on the score, it correlates with the provisional diagnosis, and then the treatment recommendations are referenced, and I'll talk a little bit more about that towards the end. And no matter what, when you do have a positive screen, it's really important to assess their intention of suicide. You can never predict who is going to complete suicide, but we can categorize them into high and low risk factors. We really do want to also assess individual coping resources, their accessible support systems, so if they're a family member, a friend, or a neighbor, or a school teacher that they can reach out to. We may also want to ask about their attitudes, and the family's attitudes actually towards interventions, mental health care, and follow-up. Additionally, really asking about the home environment screening, asking about firearms, medications, knives, etc. Those at higher risk include those patients with a plan or a recent suicide attempt, those that state current intent for suicide, those with a recent suicide ideation with current agitation or severe hopelessness, and then impulsivity and dysphoric mood. In absence of these high-risk factors, especially in the presence of a desire to receive help in a supportive family, indicate a lower risk, but again, nothing is ever black and white. If a patient does seem at high risk for suicide, it really should be an immediate mental health referral during the office visit. So this can include hospitalization, transfer to an ED, or same-day mental health appointment. Really knowing what's available ahead of time is important, so it may take a little bit of research within your office. Low-risk patients should still receive both follow-up and referrals for mental health and severe depression. And then again, all these patients you should encourage families to lock up firearms, prescriptions, and toxins that could be available to these patients. Although asking the adolescents to agree to a safety contract has not been proven to be effective in preventing suicidal behavior, this technique really can be helpful in assessing the risk, in that refusing to agree either not to harm oneself or to tell a specific person about intent to harm is a high risk factor. So that can tell you that the patient may not be safe to go home. So encourage these safety plans with the family. That's another important aspect that was recommended by the AP clinical report this year. There's going to be many challenges, but some of them you really do have to think about ahead of time. So knowing also about the laws that in different states, so Pennsylvania, New Jersey, and Delaware, very close by. So these laws do vary state to state. Asking their colleagues about their successes, so talking to social work, co-locations of mental health care, some options that primary care providers are putting in place. And then what system will you in your practice have in place for follow-up? I'm going to hand it back to Anik to use the presentation.
Hello again. So I just wanted to talk quickly about essentially effective treatment options and sort of piggybacking on what Jeremy provided about sort of mild, moderate, and sort of severe categories of depression. So patients with generally tend to stratify depression with three categories. Severe depression is going to be patients who have pretty much all of the symptoms we talked about earlier, and significant impairment in their day-to-day life. Moderate, second category, a high number of symptoms, like obsession or so, and some difficulty functioning normally, and mild depression within the state. Have minimal symptoms by about 5 or so, function normally. You might get better quality of life, but not their ability to actually engage in their regular activities and regular life. Treatment options for mild depression, standard of care is actually therapy alone. Anyone who's positive for depression should probably receive a referral to go see a therapist. And we'll talk a little bit more about what you need for a therapist for your patient. But really sort of engage with the family and the patient also the importance of participating in some mental health care and for screening positive for depression. Modern depression, again, that's about 7 symptoms of dying, impacts the quality of life, starting to impact, maybe start to mildly impact their day-to-day functioning. They might respond to psychotherapy, but they could also benefit from an SSRI. A lot of it's going to be fun that people in the moderate category of depression with patient and family see what they're interested in terms of treatment. It certainly would be well within standard of care to start a patient on an SSRI if they're not interested in therapy, or send them to therapy if they want to try that first before starting an SSRI. Ultimately, all of the studies show patients do the best with a combination of medication and therapy. And if that's something that the patient would be amenable to do, or whatever it takes to get them feeling better, would be probably a good recommendation at that point in time. In patients with severe depression, a combination of SSRI plus psychotherapy is standard of care. In terms of psychotherapy, two types of therapy that have sort of the largest, most robust data set in being effective for depression in adolescents: cognitive behavioral therapy, or CBT. That's finding interpersonal therapy, IBT. We'll probably have a little more luck finding a therapist that does CBT, but really once you sort of work with the patient and family in terms of getting into the right care. Not all therapy is the same, and a lot of people do a lot of different things. Supportive psychotherapy, which is a lot more about checking in, how was your week, tell me how your day went. Those types of things are perfectly adequate for patients with mild depression, so not always optimal, but things like CBT and IPT really involve a lot of sort of structure. There's structured sessions, there's homework, there's assignments, there's worksheets, and really it's sort of a whole program that's sort of standardized when it comes to therapy in terms of addressing a lot of the issues that are contributing to your depression. And I often tell families that I see in the emergency room, see those with some moderate and severe depression, to really try when they close the insurance company or ask or sort of Googling and looking at it, try to find that provider that can do CBT with them. So in conclusion, and we'll open up the questions, suicide really is a public health crisis that is getting worse for children and adolescents. Screening reduces risk and improves outcomes. There are many tools available to help providers screen, and it's very important to get patients into care. So thank you for listening, and we're going to open it up to questions.